Welcome back. Today we're going to talk about schizophrenia. Schizophrenia is a disturbance in reality, orientation, thinking, and social involvement. Schizophrenia is a devastating brain disease that targets young people in their teens or early 20s. Generally, the onset of schizophrenia will happen when the individual is in their college years. Schizophrenia profoundly disrupts the individual's ability to perceive reality accurately, to think clearly, to use language appropriately, to experience normal emotions, or to engage in normal social and occupational experiences. Schizophrenia is common and a serious neurobiologic illness that affects 1% of people globally and approximately 2.5 million Americans. So, what is schizophrenia? Well, as previously stated, the symptoms usually emerge during the late adolescence to early 20s. However, schizophrenia has been diagnosed in children as young as 5 years and in people in their 40s. Schizophrenia is the most common psychotic disorder. The individual is preoccupied with inner experiences. That would be hallucinations or delusions. Hallucinations are sensory perceptions with a compelling sense of reality, but no actual objective basis. Auditory hallucinations are the most common form. The client may hear the voice of God, a relative that may have passed, or two or more voices with a running commentary about the client's behavior, or voices that command certain acts, referred to as command hallucinations. This type of hallucination must be addressed carefully because the voices may command the client to hurt himself or herself or others. In schizophrenia, delusions are often loosely organized and may be bizarre. The most commonly experienced delusional thinking involves themes associated with ideas of reference, persecution, grandiosity, somatic sensations, jealousy, and control. The client may believe their body is rotting away or that they are the Son of God. Clients will visibly respond to these internal stimuli. Schizophrenia is more common in males, um, often results in chronic illness. Um, that is, this schizophrenia just is going to be something this individual has to deal with for the rest of their life. There's an increased risk of suicide, increased risk with family history of schizophrenia. The neurotransmitter involved is dopamine. And in an MRI, there are MRI CT changes. The ventricles of the brain are very large, and atrophy is noted of brain tissue. So let's talk about some symptoms of schizophrenia. Schizophrenia can be grouped into positive or negative symptoms. The positive symptoms are anything but positive for the client with schizophrenia. Positive symptoms are associated with acute onset, and they include hallucinations, delusions, disorganized thoughts, and bizarre behavior. Positive symptoms appear early in the first phase of the illness and often give rise to hospitalization. The positive symptoms are referred to as florid psychotic symptoms. These symptoms are the least important and usually respond to the antipsychotic medications. Negative symptoms persist and are destructive because they render the client inert or unmotivated. The most debilitating symptoms are the cognitive symptoms that include impairment in memory, disruption in social learning, and the inability to reason, solve problems, or to focus attention. Negative and cognitive symptoms are more likely to cause the client to be client an inability to function on the job, or engage in social activities, or care for themselves adequately and safely. So some of the nursing diagnoses for schizophrenia. One would be impaired thought process, and that's related to the delusional thinking or hallucinations. You can imagine how difficult it is to think if you're hearing voices all the time, or if you're seeing things. How difficult it must be to think accurately. Anxiety related to inaccurate interruption of the interpretation of the environment or panic level of stress. The client with schizophrenia will be afraid. They will have. They certainly will have some anxiety when they're experiencing these delusions and hallucinations. Ineffective coping, inability to trust, or inadequate support systems. Again, related to the symptoms of the disease. Social isolation. They won't want to be out in social activities, especially if they're have past experiences that were difficult for them because of their delusional thinking or their hallucinations. And then there's risk for violence, either directed at themselves or toward others, related to panic level anxiety, command hallucinations, delusional thinking, or a perception of threats. I mean, if you perceive everybody's out to get you and the voices are telling you that everybody's out to get you, you tend to fight those off, and you may become physical in fighting off what you perceive is there. So some of the interventions for hallucinations. The first would be ask the client directly about the hallucination. Ask them, what are you seeing? What are you hearing? Just be right up front and ask what the client is experiencing. You want to watch for clues that the client is hallucinating. What kind of things may the client be doing before they actually outward express that they are having some hallucinations? Are they cowering or covering their ears, or what kind of clue is there? Avoid reacting to the hallucination as if they're real. You want to tell the client that no, I don't see whatever, but why don't you tell me about it, and let them tell you what's going on. Certainly don't argue with the client. You want to what the client is seeing or hearing is real to them, and you don't want to get in an argument because you don't see it or you don't hear it. So don't negate the client's experience, but offer your own perceptions. For example, I don't see the devil standing over you, but I do understand how upsetting that must be for you. That would be the correct approach to use in this type of situation. Focus on reality-based diversions and topics such as simple projects or conversations. Just try to involve the client in something else to divert their attentions. And of course, you want to be alert to any signs of anxiety in the client. Certainly, as anxiety goes up, other issues can happen. So you want to help the client remain calm and help them not experience high levels of anxiety while they're experiencing these hallucinations or delusions. Some interventions for delusions. The first, of course, be open and honest and reliable to reduce suspiciousness. You certainly don't want to get yourself caught up in not being honest and making the client even more suspicious of his or her surroundings. Respond to delusional statements in a matter of fact and calm manner. You want to remain calm, but you don't want to feed into the delusion. Ask the client to describe the delusion. You know, what are they thinking? What's going on? And avoid arguing about the content, but project doubt where appropriate. And you really want to focus on the feelings the delusion generates. Does the delusion cause them to be fearful? Does it cause them to be grandiose and have no fear? Just what exactly are these delusions creating in their feelings? And once the client describes the delusion, don't dwell on it. Move on. You want to focus on reality-based topics. You don't want to be dwelling on the delusion that the client has just described to you. And watch for events that trigger these delusions. Environmentally, what's going on socially with the client. You should be observing what's happening prior to the client being delusional. And validate if part of the delusion is real. Yes, there is a man in the nurse's station, but I did not hear him talk about you. You want to clear up things that are creating suspiciousness. Had an example in the first clinical rotation where the client overheard me talking with one of the students, and we were trying to locate a medical record, and whatever he heard certainly wasn't what we were talking about, and both the student and I had to clarify that yes, indeed, we were just asked, where the medical records were, but he was very suspicious of what our conversation was. And of course, we always want to be cognizant of the potential for violence in the client, and your safety and the client's safety are certainly important. So, interventions for violence prevention. Well, assess the client in this situation. If you see that behaviors are escalating, or that voices are escalating, and that there may be a potential for some violence, you may want to use some verbal techniques to de-escalate the situation. Just talking to the person in a calm voice, telling them to calm down, just trying to create that less stressful, less escalated environment. Demonstrate a respect for the client's personal space. I mean, a lot of the clients will get very upset if you're in their space. No different than you would if someone is in your space. And pay attention to your surroundings. I mean, are you backed into a corner? Are you somewhere in a room where you're not going to be able to get out? Who's present in the room? You want to pay attention to where you are. And absolutely ensure your own safety first. You want to be where you can get away if the need is there. The use of physical restraints and seclusion only as a last resort, but they may be warranted for safety. There will be there'll be orders that will go along with this, but it certainly is a last resort. And these guidelines they apply for all clients who have the potential for violence, regardless of their diagnosis. Certainly, safety and doing what you have to do to stay out of harm's way is important, and to de-escalate the situation. This should be used in any situation where there's a potential for someone to get hurt. So, in evaluating your interventions, first, change is going to occur very slowly for the person with schizophrenia. You're not going to see any dramatic changes overnight or even in a few days. It's important to plan regular evaluations of the client so that you can get new information and consider the problems that need to be reassessed. Hallucinations are less, hallucinations are more, delusions are less. You want to know how they are with their medication. Have they been medication compliant? And everything that you do, how would you evaluate your nursing interventions? Periodically, you're going to have to look at what you have done, and is it working? Has the client shown any improvement, or is there some regression? So, what is Milieu therapy? Well, it's a therapeutic, safe environment provided to the patient. The environment has structure, but also offers recreational activities. What is psychosocial rehab? Well, it's therapy that aims to gain insight into the illness over time and provides employment training. Housing. It's rehab that gets you back on your feet, and so that you can function as best as possible in a community setting. Individual psychotherapy is therapy that builds a therapeutic relationship between the therapist and the client, and it provides a basis for reality orientation and assists the client to improve their coping skills. And psychopharmacologic agents, of course, that's the treatment with antipsychotics and other medications. And we'll get into some of those very shortly. So the typical antipsychotic medications, the first generation agents, are becoming less widely used because of their troubling side effects. However, these conventional antipsychotics are being revisited because of the metabolic side effects associated with the second generation agents. It's important to point out that people quit taking older medications because of the side effects, and quit taking the newer ones because of the weight gain. So some of the medications, the antipsychotics, that we'll be looking at are Thorazine and Prolixin and Haldol. These have the risk for neuroleptic malignant syndrome. We talked about that briefly in our overview. And the risk for extrapyramidal side effects greater with the typical antipsychotic medications than the atypical antipsychotic medications. So some of the side effects that you're going to see are things like Parkinsonian movements, typically called the Thorazine shuffle, something you may have heard in the past. That term is used widely. These symptoms are associated with a stiffness and a slowness in the client that they experience in their arms and legs. It'll be evident on the behavioral health unit, commonly seen in the clients who are older or on Medicaid and those that are prescribed less expensive first-generation antipsychotics. Then the acute dystonic reaction, those are muscle spasms often noted in the neck or face. These are muscle spasms of the head and neck. They can be life-threatening if they're not treated immediately. Laryngospasm, spasm of the throat in which breathing and swallowing can become impaired. So you want to be watching out for these type of side effects. Akathisia is a restlessness or pacing. It's an internal restlessness, and an external restlessness is pacing. And then Tardif Dyskinesia. That usually appears following prolonged treatment and is more serious. It's not always reversible. Tardif Dyskinesia is characterized by involuntary tonic muscle spasms, typically involving the tongue, fingers, toes, neck, trunk, or the pelvis. This affects up to 50% of the individuals receiving long-term high-dose therapy, and it can be mild to moderate and be disfiguring or incapacitating. The early signs of Tardif Dyskinesia are in and out tongue movement or constant lip smacking. So assessment of the extrapyramidal symptoms is essential, and we use the abnormal involuntary movement scale. Any score would result in a discontinuation of medication. An anticholinergic medication may also be prescribed for the treatment of EPS. The most common anticholinergic or anti-Parkinsonian agent is cogentin. Some individuals are on a daily regimen to reduce rigidity and tremors, and it can be given IM for acute symptoms. For example, in an individual who may experience neck stiffness whereby you need to take immediate intervention. And cogentin works well and relieves symptoms rather rapidly. So some other things about first generation antipsychotics, or the typical antipsychotics. Those would be the older ones. They also produce anticholinergic side effects, some being dry mouth, blurred vision, constipation, and urinary retention. Cogentin is an anticholinergic, and the side effects are not very comfortable. So that another reason we see poor medication compliance is because of the unpleasant side effects. You'll also see dental problems in older clients associated with what may be perceived as poor oral hygiene, but it is related to chronic dry mouth. Again, we did talk about this last time, but and it's something that is very rare. However, have investigated mortalities as a result of neuroleptic malignant syndrome. Although it's very rare, you need to be aware of NMS and provide immediate intervention. NMS is associated with high potency drugs such as Haldol and Prolixin. It can occur after a single dose, but more commonly occurs within the first 2 weeks. The thing that you're going to see is you're going to see the temperature can be as high as 106, severe muscle rigidity, altered level of consciousness, and certainly you want to transfer these clients immediately to the ICU, or if you're in another setting, to the emergency room. So the atypical antipsychotics you'll see more widely used now. Atypical antipsychotics control symptoms and improve quality of life for the patient with schizophrenia. Unlike the typical antipsychotics that only provide relief with hallucinations, delusions, and the positive symptoms, the atypical control both positive and negative symptoms associated with schizophrenia. The atypicals will not only provide the relief of those hallucinations, delusions, and other positive symptoms, but they will also treat the withdrawal from the world and the poverty of speech that the client may experience. EPS and NMS occur less often. However, with the atypical antipsychotics, you will see obesity, hyperglycemia, diabetes as adverse reactions, and yet this is yet another reason you'll see non-compliance with the medications. Certainly, folks that are gaining a lot of weight are going to stop taking their medication to slow the weight gain. So here are 3 examples of atypical antipsychotics. There are a huge number, and more come out weekly. The original and the oldest one and the best one is clozapine. It does cause significant weight gain, and its major side effect is agranulocytosis, produce a significant decrease in white blood cells. Olanzapine is extremely effective in both positive and negative symptoms. It may work when other antipsychotics don't work. However, it's strongly associated with weight gain. Typical on the unit, you'll know who is on Zyprexa. because they will empty the refrigerator out. Clients may stop taking Zyprexa because of the weight gain, and following stopping the medication, they'll lose the weight, and then they become psychotic. So you put them back on the medication, and they gain the weight, and they stop taking the medication to lose the weight, and they'll become psychotic again. So you can see how it can be very cyclic with medication compliance. And finally, Zyprazodone. It's a bit newer. It's not as effective, but it works. It does work well for many people. One of the things you have to teach is that it must be taken with meals, and there has to be some fat in the meals for absorption. There is some weight gain, however, it's not as significant as with olanzapine, Zyprexa. And there is never any good news when taking these medications. Zyprazodone does increase the risk of cardiac arrhythmias. So newer antipsychotics works well and do not increase the risk for weight gain as the older ones do. They're not as powerful as clozapine or olanzapine, but many people respond to them. Um, if the newer medications are working, then there's not a need to place the client on one of the older medications. Um, Depot injections are deep IM injections that are given once every 3 weeks. This improves compliance because the individual doesn't have to remember to take 1 or 2 pills a day or twice a day. One of the problems with schizophrenia is that if the individual misses a dose, the symptoms of schizophrenia may start to return, and the individual will refuse their medication. With the injection, hopefully we can prevent this from occurring. So Clozaril is the treatment of last resort. We won't want to start anyone on Clozaril because of the severe side effects or weight gain and the agranulocytosis. Um, it's highly effective in reducing hallucinations and as well as negative symptoms. Um, it's typically only given after other antipsychotics have failed. The person has to have weekly blood work, and they need to be taught to notify their prescriber if they have any infections. So, when working with someone with schizophrenia, prior to the discharge, we want to promote good health and teach them signs of relapse and to take the appropriate preventive measures. Uh, if they start to hear voices again, or the voices are getting louder, they need to come and let us know. Obviously, we don't know that those things are going on unless they tell us. Uh, we we want them to participate in non-threatening activities. Um, how are they functioning in life? We want to see improvements in self-care, that they're not coming in dirty as they may have before, or if they have a job, been able to hold a job, that's a good thing. Uh, we want them to have reasonable housing options. It's easy for the client with schizophrenia to be withdrawn. They need to be encouraged to participate in non-threatening activities, um, social groups, social relationships. Certainly, family interaction is very important. Uh, the client with schizophrenia can easily become overshadowed by more time-consuming clients on the unit. Um, and they'll remain quiet and withdrawn in the room. We want to be careful to help ensure that this doesn't happen. The client with schizophrenia needs to be brought into the environment as much as possible. And of course, prior to discharge, we want to work on medication compliance. There's nothing so disheartening than having a client with good response from medication and have them walk out the door and they have no intentions of taking their medication. Uh, I received a call one afternoon that a client had been released, and his medications were found in a trash can at a local bank just down the street. So, medication compliance is very important, and the importance of it adhering to the medication as it's ordered. Um, it's essential that the client follows the instructions on the medication. Encourage the client to share their concerns about the side effects. Talk about the weight gain and possibly what could be done, the interventions to decrease the amount of weight that would be gained. Although they're going to gain weight. Communicate client concerns with the provider. Again, it's a team effort here, and everybody should be communicating with each other. And as medications improve, it's hoped that we'll see better compliance. But we want to support the client's request for medication changes. Certainly, we are the advocate of the client, and we want to do what's best for the client. So now our client is ready to be discharged, and for clients to be discharged to the community, there's certain criteria that must be met. There should be an absence of, or certainly exceptional control of hallucinations. The client should have a support network in place, family, friend, significant other. Shouldn't be discharging them to no support. And the client must accept responsibility to care for themselves, and that there's a safe place for them to live. Um, the client needs to understand and accept referral to therapists and community providers. They have to continue their care in the community, and they need to get to those provider visits. Most clients will alternate between an acute phase or a severe psychosis and a stable phase that's not so disabling. And it's essential on discharge that everything is in place for the client to be safe to themselves, and not be a danger to others. all the necessary elements of providing safe and successful discharges, they need to be there. We need to ensure that this individual is not going to be a threat to themselves or anyone else. And even with safeguards in place, the client may require hospitalization again in the future. And with that, I look forward to seeing you in class and having some interesting discussions regarding schizophrenia, and we'll talk more about this thought disorder.